Morning, everybody. Thanks, Susan, and thanks, Ty, for having me back. It's always nice to come on down here and enjoy a weekend with you all. It's nice to see a lot of familiar faces out there in the audience today. I will say, if I pause every now and then to catch a breath, 2 weeks ago today I was hospitalized for bilateral hospital-acquired pneumonia, so I know exactly what that kid's talking about. Oxygen starvation, and frankly, wasn't quite sure I was going to make it here, but we'll see. We'll see if the voice holds up and the lungs hold up, and we'll get through this. I'm going to talk to you about clearly one of our biggest problems. When I started in heart surgery close to 40 years ago, never heard of vasoplegia. Wasn't really a problem. Cabbages seemed to go just fine. Now vasoplegia rears its ugly head to us almost couple times a week, and it's so it's so perplexing for most of us, and we don't yet, I think, have an answer, although my work with vitamin B12 I think may be a nice breakthrough. So it's all about biologic complexity, and I think we really don't understand what we do to patients. This is an outline of what we'll talk about, some of the frequency, cases perhaps at risk, consequences, maybe some of the proposed mechanisms. Treatments have been less than satisfying. There's a new emerging treatment which is perhaps a bit more satisfying. I will point out that almost everything that gets, or things that all get promoted to us as vasoplegia may not all be vasoplegia, and they certainly may not all have the single or same mechanism. So what we call vasoplegia may be this giant lumping bucket of stuff that is generally just hypotension and it's bad. And potentially in the future, wouldn't it be wonderful if we could just plain prevent it? We'll see if we get to that point. I should point out a disclosure, I didn't put one up here, but I do have some patents, some US patents on the use of B12, not for vasoplegia, but for carbon monoxide poisoning, and we're trying to work that through the FDA and get it as a first-line treatment for carbon monoxide poisoning. I'll tell you how that works as we go along. So cardiopulmonary bypass, all of what we do is complex. I still to this date think we don't really understand it. And when I talk about biologic complexity, it is to me one of the things that I always use as a great illustration for that, because once we go on to bypass, really once we heparinize the patients and head to bypass, the unintended consequences of so many different reactions, protein reactions and cellular reactions, are really incredible. And this is a slide, if you've heard me talk before, this is a slide that I kind of like. It came out of University of Florida, Phil Hess's work at University of Florida. What that is a mast cell, a mast cell down there on the right, and those are upregulated and downregulated proteins, DNAs, and turn-ons with cardiopulmonary bypass. And then there's interrelationships between each one of those. So do we have the foggiest idea what we do? And this is and then the variants and the genetic variants that happen to patients. So we really don't have a great understanding of what we're doing to patients as we spend this 90 minutes or hour and a half, or in my case sometimes 6 hours on bypass. Is it any wonder that the longer you're on and the more the horse gets out of the barn and runs away and all these proteins get upregulated, downregulated, that bizarre things happen? So what's the definition of vasoplegia? When you read the literature, excuse me, when you read the literature, there are some similarities amongst people. Generally a low systemic vascular resistance, 800 dynes per second per centimeter to minus fifth. We don't recognize that on bypass. You guys don't go calculating your dynes, centimeters, seconds to the minus fifth per all the time, but we certainly know it as a low mean arterial pressure. And you can argue whether it's a low mean arterial pressure below 60 or 50. If it's below 50 on bypass for 10, 15, 20 minutes on bypass, my sphincter's tightening, yours is, we're all running around going, hey, Spiess, what are you going to give me over here to help support my flow on this bypass machine? Everybody's eyes are looking at each other going, well, so what are you going to do? And the vasopressin starts being given, and then the norepinephrine starts being given. And if you're unresponsive to that, that's a bad harbinger of this is going to be a tough day. If you're giving those dosages of vasopressin, norepinephrine, adding as more and more vasoconstrictors and getting little or no reaction, not only will you have a bad day coming off bypass, but the mortality is going to soar, and the length of time in the ICU and organ dysfunction, renal dysfunction, et cetera, goes up. So what is it? It's an extreme vasodilatation. It's an extreme vasodilatation where the arteriolar bed, these are the 20 to 50 to 100 micron vessels, are maximally vasodilated and cannot respond to normal triggers. In other words, beta activity, alpha activity, angiotensin II, they just simply don't respond. And it's been observed in all age groups. It does happen in pediatric, cardiac as well. Is it anaphylaxis? Is it sepsis? There are overrides. Well, clearly hemorrhagic shock, and the people in trauma say, you know, we see this too, in that once we fill up the tank, in other words, once we've transfused or we've given enough lactated ringers or albumin, and we think the volume status is okay, sometimes we still see massive vasodilatation, and we can't get the patient to respond in a normal vascular way. Clearly, in liver transplantation and in liver failure, it's a big problem. What does it look like? Here's a standard anesthetic record. Most of you guys never have to look at this. I look at them all the time. I don't think, yeah, this pointer's working. That's a low blood pressure. So are these. These are, you know, here's your 50, here's your 100 blood pressure. We're never really achieving it. And if you look up here, the anesthesia team's throwing everything but frog's warts at them. We got everything going in dosages and boluses and IV drips, and there's some response, but it's not substantial, and it's not good. Got methylene blue. Here's 10 cc's of methylene blue. That went in. We'll talk about it in a bit. Nobody knows what the right dose of methylene blue is. Give them enough methylene blue till they react. 100 milligrams is sort of standard, but people have given up to 500. So we don't really know how much and when to say, well, that's not working or it is working. There's a response to it. But if you don't respond, do you give more? And when do you give more? Don't know. So going back to sort of what are the definitions, if you read Levin's work, 2006, 2009, he's the big name who's done all the retrospective and pulled all the data together. Generally, you do see these things, low SVRs. Here's one with a fairly high SVR. But sometimes they define it as catecholamine requirements. Now, that's not a disease entity. A treatment by a doctor does not necessarily mean that's a disease entity or a disease-defining entity. It just means that this just says to me frustration. It means that, okay, now we're now classifying a disease entity as the team has given up and we've given everything we can and we don't have anything more to give. But mean arterial pressures, if I classified everybody with a mean of less than 70, I'd be seeing, or this is systolic blood pressure less than 90, so this is an ICU study. But if I classified with a mean less than 70, I'd be seeing a whole lot more vasoplegia than at 40s or 50s. But so generally 50 to 60 range, and SVR less than 800 is sort of what people are talking about. There are many names potentially for the same thing. Vasoplegia is what everybody's calling it now. Vascular hypovasoreactivity, post-cardiotomy shock, and maybe in the olden days, it used to be what we called inflammatory response syndrome, or SIRS. And I think it's absolutely that, in that I think the cause for this is the body has gone wild with an inflammatory response, and the body's ability to control or to create homeostasis for that inflammatory response is exhausted. And so, just like I had pneumonia, I was laying on the gurney going, gee, I'll bet my inflammation's off the scale. Well, my blood pressure was 100/40, heart rate was 142, temp was 103.7. Like, gee, I wonder what my white cells are doing right now. Yeah, they're going like nuts, and my ability to create homeostasis is going down the tube fast. Never thought I'd want to be intubated, but I said, if you guys got to do it, let's get on with it, because I'm about to quit. Any rate, so the incidence, depending on who you read, how they define it, between 5 to 25% after cardiopulmonary bypass, and I'd say on cardiopulmonary bypass. That's where you and I deal with it, right? Generally, this starts as soon as we go on a bypass or shortly thereafter. Generally, it doesn't usually start when everything's just hunky-dory fine. We've weaned, and now we're in the ICU, and then the pressure drops, and we got vasoplegia. No, generally, it's an inflammatory event that comes on while you and I are in the picture working hard. The incidence has been as high as the mid-40s in patients with left ventricular assist devices, and maybe that's because, hang on, let me take a couple deep breaths. Maybe that's because those patients have been given every vasodilator known to mankind by cardiology and stuff just to get them to the operating room to begin with. It may also be that this case selection, you got people who are truly inflamed to begin with. They got whole body inflammation. They're sitting right on the edge. It's compensated shock one way or the other. You just got them into the operating room, moments before their body was going to give out. They're hypoperfused. They've got a great inability to react. Mortality can be as high as 25%. So is the mortality because we're hypoperfusing, or is the mortality because we getting a message from Mother Nature that inflammation here is running rampant and you haven't done anything to fix my inflammation and all of that's bad? Nobody knows. Wide open area for some cool young whippersnappers who want to make careers to investigate all this. It's clearly higher the longer it persists, and it's clearly higher if we're giving leave 'em dead, Levofed, norepinephrine. And is that because the norepinephrine itself is so bad, and if you do happen to get perfusion to a kidney and the ICU team has been giving them lots of leave 'em dead, we're not turning it back soon enough? Or is that because this is a last-ditch effort by us, and therefore it's a signal that these are the really severely bad patients who we can't, that we can't treat. Again, this guy Levin, if you look at his stuff, in a retrospective study, intraoperative hemodynamics were used, and I showed you a bunch of those. If patients had a significant decline immediately after going on a cardiopulmonary bypass, they were far more likely to become vasoplegic and the length of stay greater than 10 days. Now, unfortunately, in that paper, there's no absolute parameters. So, how often do we see a decline as soon as we go on a bypass? Well, like every time, but it should, and I stand there and teach our residents, if this pressure of 30 isn't up within the next 2 minutes, we're going to start doing something. And if it's not up within 5 minutes, we're going to start doing something more. And if it's not up within 10 minutes, let's either think of the Methylene Blue or now my vitamin B12 stuff, because we're going to get on this early, rather than you calling me 20 minutes or 40 minutes later and saying, hey, I've been fighting this for a while, I give up. I think early intervention, perhaps with some of these antioxidant therapies I'll talk about, might be far, far superior than your anesthesia team adding this vasoconstrictor, that vasoconstrictor, and leaving the other therapies until, well, we give up, we can't do anything more. So it's pathophysiology. Well, this is typical doctor talk when we say multifactorial. In other words, we don't really know, and it's probably far more than just one disease. But it's an activation of adenosine triphosphate sensitive potassium channels in the plasma membrane of the smooth muscles, causing both potassium leaks and calcium leaks. So what does that say to me? That means the cell membrane is dysfunctioning, and when the cell membrane and the proteins of the cell membrane dysfunction, that cell is starting to die. It is not functioning, it's not doing what it's supposed to do. And perivascular smooth muscle is supposed to maintain your tone. And it also is probably through an inducible form of nitric oxide synthetase. And the reason that shows up here is because that's the only thing people have really investigated. I think we have a number of what are called gasotransmitters that go on in our body now that we know of. They've always gone on, but now we're starting to learn about them. And nitric oxide is the one that people have studied the most. But now there's a lot of study about carbon monoxide and low-dose carbon monoxide. Very, very micro amounts of carbon monoxide are cellular messengers for reducing apoptosis and potentially for vascular smooth muscle tone. I'll show you some other really cool work now that we think the mechanism of septic shock is hydrogen sulfide gas. Anybody drive into this resort and smell the stink coming into the resort? That's hydrogen sulfide gas. And that's hydrogen sulfide gas from low tide over the mangrove swamps. Well, why is that? Because that's bacterial decontamination of sulfur groups, and those bacteria, which are anaerobes, are metabolizing sulfur. The first microorganisms on Earth were anaerobes, that their entire metabolism was sulfur metabolism. In your gut, you ever fart? Well, yeah. Well, anybody in this, that's hydrogen sulfide gas. Hydrogen sulfide gas is deadly. And hydrogen sulfide gas is now being investigated as a potential weapon of mass destruction. And so it also appears that hydrogen sulfide gas is given off by white cells that are hyperactive. And where are white cells hyperactive? Well, in my pneumonia, and certainly on cardiopulmonary bypass. And so now we're learning in sepsis that hydrogen sulfide gas causes massive vasodilatation, and giving norepinephrine in bucket load doses doesn't take care of the problem. So we'll get to that. And people have said, well, maybe it's a deficiency of native vasopressin, but I think what you're looking at here in the proposed mechanisms is a bunch of docs who are using old-fashioned ways of saying, well, here's what we do know about, here's what we've investigated, but I don't think we've investigated it to the length at which it really, to say that we really understand it biologically yet. Somebody else has said this happens. It's postulated that the stress response associated with MI and unstable can cause catecholamine, leading to vascular tone and reactivity. Well, sure. How many times do I take a patient into the operating room and they're either having an involving MI or they're the patient who's waiting to have their LVAD, and I give them an anesthetic and a bottom drops out. Yeah, they've been squeezing their adrenal glands every which way from Sunday, and all of a sudden there's no more adrenal output, there's no more angiotensin renin production. Maybe that happens, but I think that's far too simplistic for what. So this is again what Levin wrote in 2004, 2009, and it gets repeated over and over again with people like me from podiums. that there's an overproduction of nitric oxide, overstimulation of synthetase, inducible nitric oxide synthetase, creating way too much nitric oxide, way too much guanylate cyclase, enzyme activity inside smooth muscles. That makes cyclic GMP, you get vasoplegia, and that there's no counter activity to this. And again, I say that's true, but I do think it's not all just nitric oxide, it's these other things going on at the same time. Is it hydrogen sulfide gas released on cardiopulmonary bypass? Got no idea, nobody's ever studied it. And there are ways to study that. There are ways to find sulfate groups, there are ways to find the sulfate group tracers from overproduction of hydrogen sulfide. What about carbon monoxide? Where does carbon monoxide come from in our bodies? Carbon monoxide is produced in the breakdown of hemoglobin. And there's some work that we're actually doing in our department, not me, somebody else is doing it, looking at brain bleeds after strokes, hemorrhagic strokes. And in the microenvironment within a few angstroms of the clot itself, carbon monoxide is 100 times more deadly and 100 times higher than you and I going out and, breathing out the back end of a tailpipe. It's huge. So the natural breakdown product of hemoglobin causes carbon monoxide production. We have any free hemoglobin on cardiopulmonary bypass? Yeah. Do those enzymes work during that time? Maybe. I don't know. Nobody's ever looked at carbon monoxide production and parts per million in microenvironment during longer bypass run. The longer your bypass run, you get more red cell destruction? Yeah, I see that all the time. So these need to be studied, and they haven't been studied well, but I'll show you some interesting stuff. And it feeds back into what I'm doing with vitamin B12 in that these things are cellularly toxic. And they are cellularly toxic just like oxygen is. I came here last year and talked to you about how deadly oxygen is. So oxygen, profound oxidator, right? Oxidizer. And these things are free radicals, and they donate electrons, and they want to kill proteins, and so your body binds these really tightly, and that's why you have antioxidants floating around in you. And I can tell you that as soon as you go on a cardiopulmonary bypass, your antioxidant levels drop like a stone. And if these are produced, they will be unbound, and when they are unbound, they do their bad things. So here's a drawing we just had recently done for a big review paper. We're trying to get published on this right now. White cell, turns out cytokines increase NF-kappa B, turn on iNOS, makes a whole lot of extra nitric oxide in endothelial cells. These are endothelial cells lining the vasculature. The nitric oxide can go in or out. It can go out to red cells. It can go in here, but it tends to go in towards the smooth muscles, and that stimulates cyclic GMP. That causes leak of potassium, leak of calcium, and inactivity. Now it gets really fancy. So if we try to give things like methylene blue or vitamin B12, they tend to interfere. Methylene blue just soaks up nitric oxide. It has less effect on nitric oxide synthetase than does B12. But these other things, B12 happens to be able to bind hydrogen sulfide. FR stands for it's an iron reactive protein. So these are breakdown products of hemoglobin. This is carbon monoxide, and very, very complex slide. But the idea you get is that binding those gasotransmitters might be really what we need to do. So remember what I said about sepsis. There is a lot of new literature mostly from the ICU and from the medicine literature, that sepsis is septic shock is being driven by hydrogen sulfide gas being turned out by the white cells. So I put this picture on here because in the United States and in Canada, where we excuse me, another big, deep cleansing breath, where we move petroleum products, we move raw oil out of North Dakota and the tar sands and stuff all across the United States in these tanker cars. We lose about 100 people a year from hydrogen sulfide gas poisoning working on those tanker trucks or those tanker cars because these things burp. And that's why many towns don't wish to have, it's not just the explosion risk of having an oil tanker train coming through, but a burping oil tanker train coming through, burping off hydrogen sulfide gas is giving off a deadly gas. So hydrogen sulfide gas is really bad. And more stuff about sepsis. What's it like in cardiopulmonary bypass? Nobody's ever studied it. But I will bet you if we do study it, we'll find that it goes off the charts. So drink your red wine. I did a little last night, planning on it again today. I own a winery, some of you know that. Red wine's good for you. Why? It's filled with antioxidants. We all need our antioxidants, but here's the bad news, you can only have so much, and you can't store it up, and you can't have a big store of it just before you have cardiopulmonary bypass. And where is it important? Well, inside your red cells, and inside every cell is glutathione. The hemoglobin is surrounded by massive amounts of glutathione because hemoglobin with oxygen bound to it is such a profound oxidizer, and that's why we've evolved to have our hemoglobin inside our red cells rather than outside, because you need the antioxidants. But glutathione, when glutathione works as an antioxidant, it needs to have the electrons taken off of it, and vitamin C does that. That's why you need vitamin C. So inside your red cells are packed like little oranges on the orange tree. They're packed with vitamin C. So I had a gentleman, Joe Roderick, doing his master's thesis with me, and he came to me. He was a med student, brightest med student I probably ever met, and he said, I think I can cure carbon monoxide poisoning. And I said, why are you coming to talk to me? He said, because I've talked to everybody else in this med school and they all think I'm crazy. And he and I started working on it, and lo and behold, we proved that it works. So what you can do is you can take hydroxycobalamin, that's vitamin B12, and if you strip the electrons off of it, you can make it so that it's highly, highly reactive to bind carbon monoxide. It also happens to bind hydrogen sulfide, and it hugely binds nitric oxide. So we've proven that it works as a way to clear carbon monoxide poisoning, and and he said to me, you know, one of the hallmarks of carbon monoxide poisoning is massive vasodilatation. You see somebody who's in a fire and they're cherry red because they've been breathing carbon monoxide, their blood pressure is 50/30, and they can't get their blood pressure up. And he said, lo and behold, you give vitamin B12, blood pressure skyrockets. And I said, well, that's cool. I said, well, we have this problem in cardiac surgery called vasoplegia. And he said, well, nobody's ever investigated it for that. And I said, well, I'll do it the next time I have it, because I can give vitamin B12 and it's completely non-toxic. I can give it out the wazoo and it is non-toxic. So the next time I had a vasoplegia case, 2 weeks later, I gave it in the operating room, saved the lady's life. Went from a mean pressure of 35 to a mean pressure of 95 to 100, and the perfusionist and the surgeon were saying, what the hell are you doing up there? We're going to blow the brain, we're going to blow this, the pressure's too high. Like, wait a minute, guys, we were dying a couple of minutes ago. Give me a little credit, we'll move. So it worked really, really well. So the treatments are methylene blue, and that that is today probably the gold standard, but even though it's held up as a gold standard, I think it's pretty crap-ass treatment. And number two, it is off-label. So when your pharmacy says, hey, why don't you just give them methylene blue instead of this? This costs $300, this costs about $1,000. I remind them, neither one is FDA approved, so don't tell me that this is the gold standard. Vasopressin, I run out of vasopressin. It doesn't, after a while, it doesn't work, but maybe preventative ones in the future. So what's methylene blue? It's an aniline dye, and it inhibits guanylate cyclase, small amount of inhibition of nitric oxide synthetase, but it binds electrons. It's a profound antioxidant. It binds electrons. And that's probably its most important thing, is it's binding the nitric oxide. And it's cleared by the kidneys. And for you and I, as soon as we give it, pulse oximetry craps out. And some of your abilities to measure things like oximetry on the pump and stuff go all haywire. And patient pees blue or green, depending on how much methylene blue you've given. But it has a problem, and that serotonin syndrome, which is serotonin, excessive stimulation of the serotonin receptor can occur with it, and especially with certain other drugs, and those certain other drugs interacting together with it, very often some of these antipsychotic drugs. But now, just in the last few weeks in my hospital, we've been told we won't have fentanyl so much anymore because fentanyl's on short supply. So we're going back to Demerol. Well, Demerol interacts with this stuff and causes a serotonin response syndrome. So if somebody starts using Demerol post-operatively in your ICUs as a major narcotic, we may see more problems with that. So the cobalamins, which are hydroxycobalamin is B12. The cobalamins, and I'm going to show you some chemistry. That'll put everybody to sleep, a little chemistry. I'm going to show you some chemistry in a couple of minutes, why these things are so cool and how they quench nitric oxide itself, and probably how they quench, how they actually quench carbon monoxide. So hydroxycobalamin has been used in Europe for 40 years to treat smoke inhalation, and the reason it's used in smoke inhalation is because every time there's a fire, there's cyanide. Look around this room. Anything plastic in here? Yeah. And in a structure fire, the cyanide levels are hugely high. Don't sweat the carbon monoxide. And so they've shown that by using B12, you can bind cyanide. Cyanide is a profound oxidizer. It is a profound free radical that likes to bind to all kinds of cytokines and other things and give up and donate electrons. So it got approved in this country after being used in Europe for 40 years. It got approved in this country in 2006. So it's now available in this country through your emergency room as vitamin B12, and I'll show you what it looks like and how it's packaged. It's actually now in short supply in the United States because of me, because we are now using it for cardiopulmonary bypass. And there's only one company that makes it in Europe, and only one company that imports it into this country. It's imported through Sarasota, Florida. And the demand for vitamin B12 has just skyrocketed because of vasoplegia and heart surgery. So here's hemoglobin. Iron sitting in between some nitrogens that are holding this iron chelated in a central core. And here's what the corrin ring of vitamin B12 looks like. Isn't it fascinating and interesting that to make hemoglobin, you need this? To make hemoglobin in your body, you need this. To make DNA in your body, you need vitamin B12. Because this cobalt here in the center takes electrons, donates them, and moves them all around. Cytochrome oxidase, the cytochrome system is a heme-based system. So many of NAD, NADPH. So many of the enzymes that move electrons in our body that make energy are based on this, but how do we get them? We take this into our body through our gut. Humans cannot produce vitamin B12. We have to take this in through our gut. We massage it and we make this. Wow. So Mother Nature's telling us something, that this cobalt in here versus this iron are so basic to our existence on Earth. Well, where's cobalt and where's iron? Uh-oh, here's the chemistry. Thankfully, I can't recite this from memory, but iron and cobalt are right next to each other on the periodic table, and cobalt has a bigger nucleus than does iron. And I find that fascinating, because if what you're trying to do is you're trying to attract electrons, and this guy has more electron attraction power than that guy, maybe we can use that. So the cobalt ion has various oxidative states. Its normal oxidative state is 3+. That's what's in B12. If you have 3+ hemoglobin, what have you got? Methemoglobin. Doesn't work. Won't bind oxygen. Needs to be reduced. Hence, you have so much reducing agents inside your red cells, because oxidized hemoglobin doesn't work. So if we reduce the cobalt down to 1+, or super reduce it down to 1+, it becomes highly, highly reactive. But lo and behold, cobalt at 3+ is still a pretty damn good reaction chemistry for binding nitric oxide, carbon monoxide, and hydrogen sulfide. They are highly tightly held, and they are held 100 to 1,000,000 times tighter than they're given up. So this is a sponge for those bad actors that may be getting out there. Interestingly, nitric oxide bound B12, and this can actually be made as a drug, might be a future treatment for migraines, because nitric oxide is held far less than is carbon monoxide and hydrogen sulfide, but that's a whole different thing. So if you take, so you've got four binding sites here. Here's a 5th binding site to this nitrogen, the 6th binding site. If you got hydroxyl group on it, it's hydroxycobalamin. That comes on and off real easily. Cyanokobalamin, which is what we use for is what happens when we treat cyanide poisoning. You suck up the cyanide, it comes on here. The cyanide never comes off, and you just pee that out, and it's non-toxic. As soon as the cyanide is on there, it's non-toxic. So that's why that works. So Cyanokit is what you want. If you are on bypass and you got a blood pressure of 30, have your anesthesiologist quickly look up my papers, call the pharmacy and tell them, I want a Cyanokit from the emergency room, get it up here now, and you'll get a bunch of lip and flap. And, well, that's not, we never heard of that before. But do it, and this gets mixed. This is lyophilized 5 grams of vitamin B12. You mix it with about 200 to 250 cc's of normal saline. Run it in. How fast do you run it in? I don't know. Never done a randomized controlled trial on that. I run it in as fast as I can run it in. And when the blood pressure goes up, I stop it. When the blood pressure goes up enough, I stop it. If it doesn't go up, I go, well, that didn't work. But usually the blood pressure goes up after about 1 gram, and very often I don't need all 5 grams. So one of our next studies is to do a randomized controlled trial of this versus methylene blue in a dose response finding kind of trial. So although I did the case, I let Joe write the paper because he needs his career. But this was our first case report back in 2014. And now we just published in 2018 our 33 cases experience in cardiac surgery and 2 in liver transplantation from VCU before I moved to Florida. And as I said, in the future, we're going to do a dose response curve. I said sulfites are detoxified by B12 species as well. Nobody's done work with that. This is our paper, and it's from Canadian Journal of Anesthesiology, I think in February of 2018. You can pull it down online right now, read it, hand it to your pharmacist and say, this is what I'm basing this on. You may get a bunch of lip and flap back from them that says, hey, you know, we don't make decisions on pharmacy based on a couple of case reports, but you know, when people die, 25% of people are dying, and this has no toxicity. It's got no toxicity. You can give 1,000 times what the dose is that you're given, and it's got no cellular toxicity. So you can't see all this data from the back, so I'm going to flip through to these kinds of charts. We had responders, non-responders, responders that were rebounders, and then responders that were continued sustained response. 45% of these patients had failed on methylene blue, and 70% of those that had failed on methylene blue who got this were responders, instantaneous responders. Non-responders were 4 patients out of the total of 37, so that's a fairly low level. Our mortality rate in this overall was 16%. Is that significant versus 25%? And there's some data in some methylene blue trials that mortality is as high as 40%. I don't know, it hasn't been a randomized controlled trial. So I think Dartmouth is doing a randomized controlled trial. People are calling me all the time saying, hey, we're trying to do this. Medical College of Wisconsin has published on using it for liver transplantation. Take a look at there's a gathering round of data. I think in the future we're going to see potentially this use of prevention. And to me, this is one of the most exciting future things maybe I can contribute before this old man retires, and that's to use high-dose vitamin C for all heart surgery. Well, why in God's name would you do that? You know, that sounds like Linus Pauling. Really? So if you think about it, we need antioxidants. Our antioxidants are totally used up within the first few minutes of cardiopulmonary bypass. And in sepsis now, there is data coming out in sepsis. As a matter of fact, it was just reported in the great medical journal of NPR a couple of weeks ago on these sepsis trials and how effective this is becoming. So up until this point, there's been nothing effective in the medicine world in sepsis, but high-dose vitamin C appears to be really quite effective. And as I said, NPR, national news story, blah, blah, blah. Mortality went from 40% in their trial to 8.5%. Wow, nothing works in sepsis. What's the usual response in sepsis? Give them more antibiotics, get more norepinephrine on board, get the leave them dead, and let's pray, you know, and give them tons of fluids till they swell up like Michelin Man. So Shakespeare even knew about vitamin C. In Macbeth, he talks about vitamin C. That's kind of useless, interesting stuff for a cocktail party. He said, throw the ascorbic acid to the dogs, I'll have none of it. Well, I'll have a lot of it, thank you very much. And I think the day will come where potentially we do that and we decrease inflammation. Is sepsis same as cardiopulmonary bypass? Well, you tell me, there's a lot of overlay there. There's a lot of inflammatory overlay. And quickly, vitamin C is ascorbic acid. Dehydroascorbic acid is what actually gets taken into cells. So it takes some hydrogens off these O's, and that's what's active inside many of our cells, and you need it. It has to be there. The vitamin C works against NF-kappa B upregulation. It works in terms of procoagulation. We did some TEG studies and some sepsis models. TEG is normalized. Ever seen DIC in sepsis? Yeah, all the time. TEG is normalized if you give high-dose vitamin C. Wow. Platelets are normal. So, and this is a study of 25 patients in ICUs at VCU, and mortality rate was 63%, low dose, medium, and that led to a big national trial that's now undergoing with 350 to 400 patients, and that was the preliminary data. The preliminary data had gone from 40% to 8% mortality. Almost nobody appears to die from it. It appears to blunt the upregulation of inflammation in coronary stent patients. Should we do that? Well, maybe so. But it prevents hyperoxia-mediated coronary vasoconstriction. Well, oxygen is a profound vasoconstrictor, and so what we need to do is we need to buffer it. So these are buffering compounds. When we're on bypass, we lose our buffering. And I think I'm going to stop there and open it up for questions. I have not done the high-dose vitamin C study yet that needs to be done. We have it proposed. It's not yet funded, but our plan is to do that, and I hope in a couple of years to be able to come back to you and say, it worked. The problem is pharmaceutical houses. There is a pharmaceutical house that makes pharmaceutical-grade high-dose vitamin C for intravenous use, and they've been struggling because Big Pharma doesn't, this is cheap-ass stuff, and Big Pharma doesn't want to fund this kind of stuff. Same thing with vitamin B12. Why would Big Pharma want to fund that kind of stuff? But it's very basic physiology to mankind. Thanks very much for your attention. I'll take any questions.